Hi everybody, welcome or welcome back to this channel. I'm Shagnik Datta and in this video we'll be talking about vasculitis. This is another video of this series where we were actually discussing about the cardiovascular system from the Robbins, and we are actually picking up the texts from Robbins. Referring to that, we were actually discussing about the concepts related to the cardiovascular system. In this video, we'll be talking about the various kinds of vasculitis which occur in the human cardiovascular system. Now, before we actually get into the details of the topic and discuss about it from the Robbins book itself, let us just get some information, the general information itself. Now, as the name suggests, vasculitis, it basically means the inflammation of the blood vessels. Now, as we all know, in most of the cases, some inflammation is always related with some or other kind of infections. But in this case of vasculitis, that is the inflammation of the blood vessels, these are always non-infectious, but they are always having some kind of an immunological causes related to them. So we will now get into the classifications of vasculitis. Now, this exact classification is not there directly in the Robbins, but I've tried to sort it out and classify it in these various categories. I've basically tried to classify it into three categories, that is large vessels inflammations, medium sized vessels, and small sized vessels as well. Now, first let us get into the large vessels vasculitis, and the very first one is giant cell arteritis. Now, giant cell or temporal arteritis is a chronic, classically granulomatous inflammation of the large to small sized arteries that principally affects the arteries of the head. It is the most common form of vasculitis among the elderly adults in the United States and Europe. The temporal arteries are not particularly vulnerable, but their name is attached to the disorder since they are the most readily biopsied in making the diagnosis. So basically, the giant cell arteritis is also known as temporal arteritis. So as the name suggests, it must be very indicative that the temporal artery must be involved. But in most of the cases, the temporal artery is not involved, but the temporal artery sample is biopsied to make the diagnosis and hence the name. Vertebral and ophthalmic arteries as well as the aorta, that is giant cell aortitis, also can be involved. Because ophthalmic artery involvement can lead to sudden and permanent blindness, affected persons must be diagnosed and treated promptly. Now let us talk about the pathogenesis. Giant cell arteritis likely occurs as a result of a T cell mediated immune response to an as yet uncharacterized vessel wall antigen. Pro-inflammatory cytokines, especially the TNF and the anti-EC antibodies, also contribute. The characteristic granulomatous inflammation and association with certain major histocompatibility complex class II haplotypes and excellent therapeutic response to the steroids all strongly support an immune etiology. The predilection of the vessels of the head remains unexplained, although one hypothesis is that vessels in various parts of the body develop from the distinct antigen and may therefore express unique antigens. Now let us just talk about the morphological characteristics of the disease. It involves arterial segments develop intimal thickening that reduces the luminal diameter. Classic lesions exhibit medial granulomatous inflammation centered on the internal elastic membrane with elastic lamina fragmentation. There is an infiltrate of T cells, basically CD4 plus more than CD8 plus, and the macrophages. Although multinucleated giant cells are seen in approximately 75% of the adequately biopsied specimens, granulomas and giant cells can be rare or absent. Inflammatory lesions are only focally distributed along the vessels, and segments of relatively normal artery may be interposed. The healed stage is marked by medial attenuation and scarring with the intimal thickening, fragmentation of greater than 30% of the circumference of the internal elastic lamina, and the adventitial fibrosis. Now let us talk about the clinical features seen in these kinds of diseases, that is temporal arteritis or giant cell arteritis. The temporal arteritis is a rare before age 50. So basically it occurs and affects the people of age greater than 50 years. Symptoms may be only vague and constitutional, such as fever, fatigue, weight loss, or may involve facial pain or headache. Most intense along the course of the superficial temporal artery, which can be painful to palpation. Ocular symptoms associated with the involvement of the ophthalmic artery abruptly appear in about 50% of the patients. These range from diplopia to complete vision loss. Diagnosis depends on the biopsy and histologic confirmation. However, because the giant cell arteritis can be extremely focal within an artery, adequate biopsy requires at least a 1 cm segment. Even then, a negative biopsy result does not exclude the diagnosis. Corticosteroids or anti-TNF therapies are typically very effective. Now, as we have completed the text from the Robbins, let us just get all these informations together and let's focus on the main informations that we need while studying. So basically the aorta or the major branches are affected in this case, such as the carotid artery. Now, as we all know, carotid artery can be external carotid artery, and hence the superficial temporal artery can also be affected. And as the internal carotid artery might get affected, the ophthalmic artery is related as such. Now let us just talk about the clinical features that we just discussed. The most common clinical feature is headache, which is supposed to be localized, and most specific is jaw claudications. Other than that, some non-specific clinical features are also present, like fever, malaise, joint pain, muscle pains, which is also known as polymyalgia rheumatica. Now, as we talk about joint pain, shoulder girdle pains is more as compared to the pelvic girdle pains. Now let us talk about the diagnosis. The diagnosis suggests there will be increased TLC levels, there will be increased ESR levels, which is more than 50 mm per hour, there will be increased interleukin 6, increased fibrinogens. But the investigation of choice remains the temporal artery biopsy, and hence the name is temporal arteritis. And as we just talked about the treatment, the drug of choice shall be IV steroids. Now let us get to the next large vessel disease, that is Takayasu arteritis. Now Takayasu arteritis is a granulomatous vasculitis of the medium and larger arteries, characterized principally by ocular disturbances and marked weakening of the pulses in the upper extremities. Hence the name pulseless disease. Takayasu arteritis manifests with transmural fibrous thickening of the aorta, particularly the aortic arch and the great vessels, with severe luminal narrowing of the major branch vessels. Takayasu arteritis shares many attributes with the giant cell arteritis, including clinical features and histology. Indeed, the distinction is typically made based on the age of the patient, and with the biopsy reports and the histological reports and also the clinical features are almost the same as of the giant cell arteritis. As we've seen in the giant cell arteritis, most of the patients were above 50 years. So those over 50 years of age are designated as giant cell arteritis, while those under 50 are designated as Takayasu arteritis. Although traditionally associated with the Japanese population and a subset of human leukocyte antigen haplotypes, Takayasu arteritis has a global distribution, and autoimmune etiology is very likely in this case. Now let us just talk about the morphology of this Takayasu arteritis. Takayasu arteritis classically involves the aortic arch. In a third of patients, it also affects the remainder of the aorta and its branches, with pulmonary artery involvement in half of the cases. coronary and renal arteries may be similarly affected. There is irregular thickening of the vessel wall with intimal hyperplasia. When the aortic arch is involved, the great vessel lumens can be markedly narrowed or even obliterated. Such narrowing explains the weakness of the peripheral pulses. Histologically, the changes range from adventitial mononuclear infiltrates with perivascular cuffing of the vasa vasorum to intense mononuclear inflammation in the media. Granulomatous inflammation replete with the giant cells and patchy medial necrosis is also seen. The histology is essentially indistinguishable from giant cell temporal arteritis. As the disease progresses, collagenous scarring with admixed chronic inflammatory infiltrates occurs in all the three layers of the vessel wall. Occasionally, aortic root involvement causes dilation and aortic valve insufficiency. Now let us talk about the clinical features of Takayasu's arteritis. Initial symptoms are usually very non-specific, such as fatigue, weight loss and fever. With progression, vascular symptoms appear and dominate the clinical pictures, including reduced blood pressure and weaker pulses in the upper extremities. Ocular disturbances, including visual defects, retinal hemorrhages and total blindness, and also neurologic deficits might be appreciated. Involvement of the more distal aorta may lead to the claudication of the legs. Pulmonary artery involvement can cause pulmonary hypertension. Narrowing of the coronary ostia may lead to myocardial infarction, and involvement of the renal arteries leads to systemic hypertension in roughly half of the patients. The course of the disease is variable. In some patients there is rapid progression, while others enter a quiescent stage at 1 to 2 years, permitting long-term survival, albeit with visual or neurological disease. Now let us just bring down everything as we are doing for every other disease. It usually affects less than 50 years of people. Mostly the Asians are affected, most commonly the Japanese, and hence the name is a Japanese abbreviation, the Takayasu's arteritis. Now here we commonly see aortic arch involvement, the aortic arch syndrome, hence the name is also said. Now, if there is trouble at the origin point of the vessels, there is less blood in the vessels. As a result, feeble or weak pulses are found, hence is also known as pulseless disease. On microscopic examinations, granuloma formations are very much appreciated. Now, if we talk about the clinical features, there are neurological manifestations. There will be weak pulses, sudden onset of blindness present there, but the disease is very poorly prognosed. Now, if for some reason the renal artery is involved, there is presence of activation of the renin-angiotensin-aldosterone system. As a result, there is some resultant hypertension, hence is known as renovascular hypertension. Now, this in renovascular hypertension is most commonly seen in elderly individuals in case of atherosclerosis as well, and hence the disease becomes very much difficult to be differentiated. In young individuals, it is seen in cases in India, but in Western countries it is mostly seen in cases of fibromuscular dysplasia. Now let us talk about the diagnosis. We usually do an angiogram and hence find narrowing of the affected vessels. We do a biopsy and found granuloma positive and giant cell positive as well. With this we come to an end of the large cell vessels inflammation, that is the large vessels vasculitis. Now let us talk about the medium sized vessels. The first one is Buerger's disease, also you can pronounce it as Buerger's disease, but remember the spelling, it is Buergers, because there's another disease which we will come to in the subsequent videos maybe, that is Buerger's disease, which is literally spelled as a burger. Now, thromboangiitis obliterans is another name for the Buerger's disease. Thromboangiitis obliterans is characterized by segmental thrombosing, acute and chronic inflammation of the medium and small sized arteries, especially in the tibial and radial arteries, that often leads to vascular insufficiency, typically of the extremities. It occurs almost exclusively in heavy cigarette smokers, usually before the age of 35. Now let us talk about the pathogenesis. The strong relationship with cigarette use involves either direct idiosyncratic EC toxicity caused by some tobacco component or an immune response to the same agents that have modified host vascular wall proteins. Most patients with Mbbs disease have hypersensitivity to the intradermally injected tobacco extracts, and their vessels exhibit impaired endothelium dependent vasodilation when challenged with acetylcholine. There is an increased prevalence in certain ethnic groups such as in the Indian subcontinent or the Japanese, and an association with certain major histocompatibility complex haplotypes. Now talking about the morphology, the affected vessels of the thromboangiitis obliterans show acute and chronic inflammation accompanied by luminal thrombosis. The thrombus can contain small micro abscesses composed of neutrophils surrounded by granulomatous inflammation. The thrombus may eventually organize and recanalize. The inflammatory process extends into contiguous veins and nerves, and with time, all three structures can be encased in fibrous tissues. Now let us just talk about the clinical features. The early manifestations include Raynaud's phenomena, instep of foot pain induced by exercise, instep claudication, and a superficial nodular phlebitis, that is venous inflammation. The vascular insufficiency of Mbbs disease tends to be accompanied by severe pain even at rest, undoubtedly due to neural involvement. Chronic extremity ulcerations can develop, progressing over time, occasionally precipitating to frank gangrenes as well. Smoking abstinence in the early stages of the disease can often ameliorate further attacks, so smoking should be stopped as soon as the disease is diagnosed. However, once established, the vascular lesions do not respond to smoking abstinence. So let us just summarize what did we learn in thromboangiitis obliterans. It is also known as Mbbs disease. So here we find necrotizing granulomatous inflammations. The most common vessels affected are arteries more than veins, more than nerves. Now lymphatics are not affected, only arteries, veins and nerves are affected. It is usually seen in young smokers. Now there at times is presence of tibial artery involvement. As a result, there is decreased blood supply and pallor in the affected area present. There is presence of intermittent claudications. As a result, at rest, symptoms are not present, but while walking, the pain increases. And there might be presence of radial artery involvement. And as just said, it also involves something called as the Raynaud's phenomena, which you can refer to in page 516 of Robbins, where there is decreased blood supply causing pallor in the affected area, and as a result there is intermittent claudications as well. Now let us just talk about the diagnosis. Mostly it is diagnosed by the presenting clinical manifestations, but microscopic examinations show micro abscess formations and granuloma formations as well. Now let us talk about the treatment plans. We shall first advise the patient to quit smoking. There might be presence of amputations, vasodilators can be used, and surgery turns out to be the last option. Now let us just talk about another very important medium-sized vessel vasculitis, that is Kawasaki's disease. Now Kawasaki's disease is an acute febrile, usually self-limited illness of infancy and childhood associated with large to medium-sized vessels arteritis. 80% of the patients are younger than 4 years of age. Its clinical manifestation stems from the involvement of coronary arteries. Coronary arteritis can result in aneurysms that rupture or thrombose, causing myocardial infarction. Originally described in Japan, the disease is now recognized in United States and elsewhere as well. In genetically susceptible persons, a variety of infectious agents have been posted to trigger the disease. The vasculitis may result from a delayed type hypersensitivity response directed against cross-reactive or newly uncovered vascular antigens. Subsequent cytokine productions and polyclonal B cell activation results in autoantibodies to the ECs and SMCs that precipitate the vasculitis. So now let us talk about the morphological features. Kawasaki disease vasculitis resembles that seen in the polyarteritis nodosa. We will be discussing in the later part of this video itself. There is a dense transmural inflammatory infiltrate, although the fibrinoid necrosis is usually less prominent than in polyarteritis nodosa. The acute vasculitis typically subsides spontaneously or in response to treatments, but aneurysm formation due to wall damage can appear. As with other arterites, healed lesions can also exhibit obstructive intimal thickening. Pathologic changes outside the cardiovascular system are rarely significant. Kawasaki's disease typically presents with conjunctival and oral erythema and blistering, edema of the hands and feet, edema of the palms and soles, a desquamative rash, and cervical lymph node enlargement. Hence, its other names are mucocutaneous lymph node syndrome. Approximately 20% of the untreated patients develop cardiovascular sequelae ranging from asymptomatic coronary arteritis to the coronary artery ectasia to giant coronary artery aneurysms. The last mentioned are associated with rupture, thrombosis, myocardial infarction, or sudden death. With the intravenous immunoglobulin therapy and aspirin, the rate of symptomatic coronary artery disease is less than 4%. So, as we just discussed, it is mostly the kids less than 4 years who are affected. Let us talk about the pathophysiology. There is some kind of history of viral infection resulting in immune system activation. As a result, the T cells and anti-EC antibodies are present, resulting in the clinical features that we shall be talking about. What are the clinical features? There shall be fever for more than 5 days, plus there might be conjunctivitis, which is of non-exudative type. There might be presence of rashes, edema, adenopathy, mucosal ulcers, which is also known as strawberry tongue. Now, it also has got coronary artery involvement resulting in thrombosis and coronary aneurysm resulting in myocardial infarctions. Now, while diagnosis, we see usually the increased TLC counts, increased ESR and increased PIC. As a result, there is increased risk of myocardial infarction. While we do biopsy, we get transmural inflammatory infiltrates being present. Now, let us talk about the last disease, that is polyarteritis nodosa. Now, what is polyarteritis nodosa? PAN is a systemic vasculitis of the small or medium-sized muscular arteries that typically affects the renal and visceral vessels but spares the pulmonary circulation. So, it is basically affecting the renal circulation and the visceral vessels of other organs, but the pulmonary circulation is spared. Now, talking about the morphology, PAN is associated with segmental transmural necrotizing inflammation of the small to medium-sized arteries, often with superimposed aneurysm and or thrombosis. Kidney, heart, liver and GIT vessels are involved in descending order of frequency. So basically the heart vessels are more affected than the liver vessels and the GIT tract vessels. Lesions usually involve only part of the vessel circumference with a predilection for branching points. Impaired perfusion of parenchyma distal to the lesions results in ulcerations, infarcts, ischemic atrophy or hemorrhage. During the acute phase, there is transmural inflammation of the arterial wall with a mixed infiltrate of neutrophils, eosinophils and mononuclear cells, frequently accompanied by fibrinoid necrosis and luminal thrombosis. Older lesions show fibrous thickening of the vessel wall extending into the adventitia. Characteristically, all the stages of activity from early to late coexist in different vessels or even within the same vessel, suggesting ongoing injury. Now, talking about the clinical features, the PAN is primarily a disease of the young adults but can occur in all age groups. The course is frequently remitting and episodic with long symptom-free intervals. Because the vascular involvement is widely scattered, the clinical signs and symptoms of PAN can be quite variable. Typical presentations involves some combinations of rapidly accelerating hypertension due to renal artery involvement, abdominal pain, and bloody stools caused by vascular gastrointestinal lesions, diffuse myalgias, and peripheral neuritis, predominantly affecting the motor nerves. Renal involvement is often a major cause of mortality. Untreated PAN is typically fatal. However, immunosuppression can yield remissions or cure in 90% of the cases. So, the most common population which is affected are the young adults. The immune complexes induce type 3 type of hypersensitivity reaction resulting in fibrinoid necrosis. As a result, there is formation of HBs antigen and anti-HBs antibody reaction resulting in deposition in multiple organs. So the small vessels are usually spared, but the lungs are not involved as well. When the kidney is involved, the renal artery get involved, the RAS system gets activated, and there is resultant hypertension. When the GIT is involved, there is presence of pain and blood in the stools. And as you know, blood in stools is known as melena. So you can remember that. The skins, if involved, may present with nodules, papules, and ulcerations. If the nerves get involved, these are mononeuritis multiplex which are present. If the joints get involved, there is presence of arthralgia, and if CNS gets affected, there is presence of seizures. Diagnosis: if we talk about biopsy, we find transmural inflammations. In the early phase, fibrinoid necrosis is present and neutrophilic infiltrations is appreciated, but in the late phase, there is presence of fibrosis, which is basically named as string of pearls appearance. The most common cause of death in this case of polyarteritis nodosa is renal failure. Treatment is by steroids and cyclophosphamide, which is basically based on immunosuppressive therapy. So with this, we come to an end of discussion of these videos where we have discussed about the large vessels vasculitis and the medium sized vessels vasculitis. In the next video, we will talk about the small vessels vasculitis, and we will also discuss about a few more in general topics related to blood vessels such as atherosclerosis, and we will end our discussions on the cardiovascular system. I hope you liked this video. If you do, please hit the like button, subscribe to the channel, and share this video who might find it helpful as well. Thank you. All the best.